Hello and welcome. Today we will talk about interpretation of cardiotocographic recording for a patient who is in labor. We will do this through the S-bar method of assessment, recommendation, communication. S stands for situation, B is background, A is assessment, and R is recommendation or reporting. The assessment of fetal heart rate will be done using the recent NICE recommendations. Imagine a situation. You are starting the evening duty in the labor room and the senior registrar asks you to go to the patient in room number 1. This patient is having continuous fetal heart rate monitoring. You are asked to look at the CTG recording and give you a report on your findings. Unless it is an emergency, before looking at the CTG, you should always try to understand the background of the patient to identify special factors which have to be taken into consideration before reporting. Find out about the history during the antenatal period, the risk factors identified based on history taking, examination, laboratory investigations, ultrasound findings, progressive changes during pregnancy, and also check the WHO labor care guide, which has been started for the patient in the labor room to understand the progress of labor and the process of labor. Along with the background check, always introduce yourself to the patient and inform her how you are going to have a look at the CTG and you are going to report back to the senior doctor in the labor room. If required, recheck some of the findings on the history or the present condition. Ask the patient if she wants to ask you any questions. This is part of the counseling and the introduction that you would do for any patient. After finding out the details of the background of the patient, now we will start the assessment process. Before actually reading the CTG, you want to know whether the recording is being done properly. Are the uterine contractions being recorded? You will know this if the bottom half of the graph is also showing a recording. Check if there is any confusion or any similarity between the maternal pulse and the fetal heart. Maybe the fetal heart is not being picked up and the maternal pulse is being picked up and recorded. Once you are sure that the recording is being done properly and the fetal heart recording is true, start analyzing the tracing. Now, the National Institute for Health and Care Excellence in the United Kingdom is a body that issues recommendations and guidance, which is based on evidence and developed by independent committees, including professionals and lay persons, and consulted on by stakeholders. The guideline for fetal heart rate monitoring was published in December 2022, and some changes have taken place for better understanding and communication and reaction to CTG recording. This is a summary table of the changes in the NICE guidelines. The findings are tagged in different colors. Each color has a meaning. The first consideration is that the findings are now tagged as white, indicating no risk, amber as medium risk, and red as high risk. The table also gives you an idea about the reporting for each aspect of the observation, that is, uterine contractions, baseline fetal heart rate, variability, decelerations and accelerations, and a categorization guidance. Here we see the first column, that is uterine contractions. This means you must count the contractions over a 10-minute period. This counting will be done on the CTG recording. If there are less than 5 contractions, it means risk is low. If the contractions are 5 or more over a 10-minute period, this means this is a risk situation and it is categorized as amber. If there is a hypertonic contraction, this is also an amber sign. This slide shows a reassuring pattern, and the baseline fetal heart rate is 130. This is 120. This is 160, and so in between the two is 30 beats between these, and there are 3 lines: 1 line, 2 line, and 3rd line. So between 1 and this line is 130, then 140, and then 150. So in this recording, the baseline heart rate is 130 to 140 beats per minute, preserved beat to beat, and long-term variability. These are also accelerations which are seen, and in this particular recording, there is no uterine contraction being recorded. So this means that this is probably in the antenatal period. In this slide, we will show you how the fetal heart recording and the uterine contraction is displayed on the paper that is run in the CTG machine. The paper is a graded paper, and each small square is 30 seconds and each large square is 60 seconds or 1 minute. And this depends on the rate at which the machine is being run. Majority of times, the machine runs at a rate of 1 centimeter per minute. So the next question is that how is the toco dynamometer or the belt which measures the uterine pressure, how is that measured and how is it displayed? So this displays in millimeters of mercury, and it's a measurement of pressure externally, not internally, but externally. So in the first stage of labor, the uterine contraction gradually increases from 25 millimeters of mercury to 50 millimeters of mercury, as you can see here, about roughly 45 millimeters of mercury. However, in the second stage, it can typically go up to as much as 100 or 80 to 100 millimeters of mercury. On the left-hand side is the fetal heart rate recording, and the fetal heart rate recording, the paper is graded in such a way that there is 60 beats per minute, 80, 100, 120, 140, 160, 180, and then 200. That means that the middle line between 160 and 180 is 170. That means that between 160 and 70, it is 5. So when we are looking at the variability of the fetal heart, we are looking at these little jumps up and down, up and down, up and down. And we measure this for the sake of variability. So variability tells us that is the variability normal or is the variability abnormal? If the fetal heart continues to jump up and down between 5 to 25 millimeters, 5 to 25 beats per minute, this is an indication of good variability. If it is less than 5 beats per minute, then it is indication of poor variability. And if it is very high, then it is an indication of abnormal fetal heart with a very high variability. But variability is a good sign. It is a sign of well-being, and because this fetal heart rate recording is being done with help of a Doppler and not with the electrocardiographic recording of the impulses being sent by the heart. So this recording is actually a composite recording which the machine records as it is recording the fetal heart, the blips of the fetal heart. It converts it into a rate, and this rate is then mentioned on this piece of paper, and this is indicating the variability of the heart rate. Now we move on to the column for variability. The variability is determined by looking at the minor oscillations in the fetal heart rate, which usually occurs at 3 to 5 cycles in a minute. Measure it by estimating the difference in beats per minute between the highest heart rate and the lowest heart rate in a 1-minute segment of the trace between the contractions, excluding decelerations and accelerations. So the categorization of the fetal heart rate variability is done as follows. If the beats are fluctuating 5 to 25 around the baseline, this is normal variability, and it is categorized as a white signal. However, if the beats are less than 5 for over 30 to 50 minutes, or if they are greater than 25 up to 10 minutes, then it is indicated as an amber signal. In a red signal, the beats are fewer than 5 beats a minute for more than 50 minutes, or they may be more than 25 minutes for more than 10 minutes, or if they are sinusoidal. Then in all these cases, the fetal heart rate variability is considered as abnormal and falls in the red category. So in this particular slide, you can see that this is the rate of the heart. This is the baseline. And as you can see, the line is very thin and almost continuous with very little variability here. But then again, the variability starts to improve here. But over here, the variability is very low. So even if the variability is very low for a short period of time, it doesn't really matter, but it should not be present for a long period of time. So now we move on to the column of decelerations. Decelerations are defined as transient episodes when the fetal heart rate slows to below the baseline level by more than 15 beats a minute. And each episode will last 15 seconds, or an exception to this is in a trace with reduced variability, even if it is the shallow deceleration. So decelerations could be early, variable, or late. When we categorize them, we see that if there are no decelerations, or early decelerations, or short-term variable decelerations, then they are considered to be low risk and in the white category. However, if the decelerations are repetitive and variable with any concerning characteristics for less than 30 minutes, or if they are variable and more than 30 minutes, or if they are repetitive, late decelerations for less than 30 minutes, then this is considered to be an amber alert. In case the decelerations are variable and repetitive and they are for more than 30 minutes, or if there is acute bradycardia with prolonged deceleration lasting 3 minutes or more, then it is considered to be a red alert and a red sign. So important to remember that the longer the deceleration, the later the deceleration, the higher the risk of fetal compromise, especially if the decelerations are accompanied by a rise in the baseline, a tachycardia, or reduced or increased variability. So here we see that there are 4 important signs that there is either tachycardia or there is an increase in the baseline, as was seen earlier, or if there is a deceleration and this deceleration is especially variable and prolonged and continuing, and in addition to all that, there is the variability is reduced or highly increased. These are all dangerous signs indicating that there is a high risk situation. So in this particular slide, we see that this is the top part, which is indicating the fetal heart tracing, and this is the bottom part, which is indicating the uterine contraction. And as the uterine contractions are very high, they are probably second stage contractions. And as you can see here, that the decelerations are not early because they are not starting here with the start of the uterine contraction. They are slightly late, but there is a shouldering sign over here and over here, over here and over here. So these are variable decelerations with pre and post accelerations or shouldering, and the fetal heart rate is 150 to 160 beats per minute, and the variability is preserved. And if the patient is in the second stage of labor, then this is not serious. But if she is in the first stage of labor, maybe she is having hypertonic uterine contractions. So as we have seen before, the fetal heart rate can only be translated in after you know all the background characteristics. But if you just look at it, you can just define this saying that the baseline is normal, the variability is normal, there are decelerations which are late, and there is some shouldering indicating that there is no total fetal asphyxia at the moment because shouldering is occurring. In this slide, we see that the baseline is close to 170 to 180 all the way around. Here we have the uterine contractions, and these contractions are also quite strong contractions. But we see that there is a loss of variability. The beat-to-beat variability is not very normal and good, and there's a flattening of the heart rate. In addition to that, some variable but mild decelerations are also present. So for example, here, you would not call this a deceleration, but here, this is the start of the uterine contraction, but this is appearing later and then going back up. And here too, there's a shallow and slightly variable deceleration present here. But this one is more marked, and this one is slightly more marked, but this one is very shallow. In this particular slide, we see a non-reassuring pattern of late decelerations. We are calling this late decelerations because the uterine contraction is starting here, but the deceleration is starting here. So it is starting after the onset of the start of the contraction, and then the peak is the most bottom point of this contraction, or the trough of this contraction, is after the contraction has peaked. And as the uterus is recovering, the fetal heart rate is troughing and falling down and then slowly picking up again. And here we see a shallow and subtle late deceleration. But the beat-to-beat variability here is normal, but however there is tachycardia. So you have to see now there is no tachycardia. The fetal heart rate is 160. So in this particular case, so this is 180, this is 200, and this is 160. So there is the baseline is fairly normal. There is variability. There are decelerations. This is variable deceleration, which is a late deceleration, but this is a shallow deceleration. So the decelerations are not persistent, and here it is late. Here it is very shallow. Here it is late and deep, but here it is kind of coming up with the contraction and recovering completely before the end of the contraction, and very shallow. This slide is showing a late deceleration with loss of variability. This is an ominous pattern, and immediate delivery is indicated. So as you can see here, that the fetal heart is almost a flat line, and this should not be a flat line. There should be a lot of variation in this line, which is indicating good variability. And again, here you have the uterine contraction, the height of the uterine contraction, and the fetal heart rate starts to drop here, and it troughs or gets to its lowest point at the end of the uterine contraction and takes some time before it can recover. Similarly, this is also a late deceleration. In this CTG, we can see that there is a severe variable deceleration with overshoot. However, variability is preserved. So you can see that these are uterine contractions, and these are the variable and the late decelerations which are persisting here, and then again here, and The variability is preserved, so we have to, so all you can say is this is the baseline, these are this is the variability, there is no acceleration as such, except perhaps you can, but this, and you can call this, or you can call this as shouldering because it is right at the end of the deceleration, so you can't call it an acceleration, but you can call it a shouldering. And this is a deceleration, and this deceleration is late, and this deceleration is also late, and this deceleration is also late. So they are variable and late decelerations. This slide is showing a saltatory pattern with a wide variability. The oscillations of the fetal heart rate above and below the baseline exceed. So if you imagine that this is the baseline, then the fetal heart rate is really exceeding above and below the baseline, above 25 beats per minute. So if this is like 30, and this is 60, this is 90, this is 120, and 120, then this is 150, 180, and this is 200. So you can imagine that the distance between this and this is 30. So you can imagine between this and this is 60. So you can imagine that this pattern is going 60 beats per minute up and then down, up and down, 30 beats per minute up and then down. So this is a saltatory pattern, and definitely there is a this can be caused by acute hypoxia, mechanical compression of the umbilical cord. It may be seen in the second stage of labor, or it may be an alert sign of hypoxia progressing to acidosis. So if a patient has this kind of a CTG, put them on their side, stop the oxytocin, give them oxygen, give them fluids and hydration, and then see if the fetal heart rate settles down. Or if the patient is near delivery, then this kind of CTG will not be considered to be highly abnormal. But if this is the first stage of labor, then this CTG will be considered highly abnormal. So we use the categorization in this way, that white means no deceleration, and amber means repetitive variable deceleration, so we include the categorization of the CTG as part of the full assessment of the condition of the woman and the baby. So the CTG can be an important tool which can communicate the current state of the fetus, and it should be used together with antepartum and intrapartum risk factors. And as we have noted before, there are 4 important parts to it: the contractions, uterine contractions, the baseline, what is the baseline, whether it is high, whether it is low, whether there's a rise during the CTG recording, and what is the rise, what is the variability, and what are the, if there are any decelerations. All 4 features are normal, then this is a normal CTG, if all of them are white. If there is any feature in amber, then this is suspicious CTG. 2 or more amber is pathological, and any one feature in red is pathological. So how do you report and how do you recommend after review of the CTG? Consider any change in the categorization of the CTG alongside other antenatal and intrapartum risk factors for hypoxia. For example, if the fetus is intrauterine growth retarded, for example, if the mother is anemic, has a cardiac problem, or if she is bleeding, discuss the change and its implications with the woman and consider her preferences when deciding how to proceed. Special considerations for cardiotropographic traces are present in the second stage of labor. There are some simple techniques that you must use to improve the circulation and the oxygenation of the fetus if there are any abnormal changes in the CTG. So before any decisions can be made, or before the baby can be delivered or expedited to deliver, there are certain things that you can do in the interim period. You can change the maternal position to the left lateral position. You can stop the syntocinon infusion. You can give oxygen to the mother. You can give fluids to the mother, and by giving intravenous fluids. So this presentation has given you the rules for interpretation of the CTG of a woman in labor. Remember the acronym BVAD and follow it to interpret the CTG which is placed in front of you. But remember, background information is very important. So baseline, we have defined what is the meaning of baseline, variability, accelerations and decelerations. Thank you very much. With this, we come to the end of this presentation.